So good morning, everyone, and welcome to this seminar called Presentation and Lessons Learned from 3 eHealth Forte programs. I'm the host, and my name is Professor MoBILE at the Department of Health Medicine and Caring Sciences at Linköping University. So, and this is seminar number 5 in our MoBILE Research Program seminar series that is also given in collaboration with the strategic research area in eHealth as well. So most welcome. And today's program looks like this. So we have 3 presentations. It's myself and 2 of my two guests that I've invited. And then we will have a joint discussion and questions from the audience afterwards. I will wait a little bit to introduce my guests because I will just give you some background to why we are here today. So in 2018, there was a special call from Forte in healthcare science. And one of the topics was also eHealth. And 7 programs were funded in the end, and 3 of them are represented here today. So that's a little bit the background why we are here, to kind of hear about each other's program and share some experiences and lessons thus far. So I'm very happy to have you all here today. And of course, I mean, getting such a program is a lot of joy. And I'm sure the other programs were very happy as well. On our side, we were very, very happy. So this picture illustrates that because one of the junior researchers in the program, he was so happy, so he screamed out loud in one of the grocery stores, and people were coming up and wondering what happened in his life. That was so fantastic. And I mean, getting such a program is like getting a Christmas present. You get a lot of opportunities. You can focus on research for several years. It's bigger than just a single project, so you can do more than just doing a project. So a lot of opportunities, and you can kind of work even more with your passion compared to just a single project. So it's a huge opportunity, of course. With it also comes a lot of work, a lot of responsibilities, and also achievements to be made. So even though I think today we will, of course, focus on the opportunities and possibilities with our programs, but I'm also eager to hear if you have any challenges that you experienced, some bumps along the way, because that's also how we learn. So please share if you have these experiences and kind of things that you want to share with us as well. But then back to the program. So I will start by presenting our program, the MoBILE program. And then I have Professor Inger Christensen Hallström from Lund University that will present their program. And also Professor Naveen Nenge from University of Gothenburg and Umeå University that will present their program. So most welcome to you both. I'm very, very happy to have you here and look forward to your presentations. And I'm sorry if I didn't pronounce your name correctly, so please help me later. And then we will have a joint discussion and also questions from the audience. I mean, focusing on collaborations, but also more general questions about our programs, of course. So I'm very excited, so I hope that you all are. So our program is called the MoBILE Research Program. So it stands for Mobile Health Multiple Lifestyle Behavior Interventions Across the Lifespan. And I will give you a quick overview and also some lessons learned thus far. And this is the members of our program. Most participants are presented in the photo, not our most recent recruitment. We just have an international postdoc that arrived, so he's not in the photo, but otherwise I think everyone is there. And the background for our program is that I came here in 2018 as a professor in April, and I read about the call. So then I contacted the other group. We didn't know each other from before, but it ended up really well. It ended up with an application, and it was funded. So this is a program with 2 research groups covering 4 lifestyle behaviors. So from my side, my group focuses on nutrition and physical activity, and the other group have more experience in alcohol and smoking cessation. So together we were a great team to kind of covering all 4 lifestyle behaviors. We also had some international co-applicants on the grant as well. And to give you some background, I mean, of course, everyone knows that inadequate physical activity, unhealthy diets, smoking, and harmful use of alcohol increases the risk of non-communicable disease and premature death. And healthcare has a responsibility to provide support for patients in need of changing unhealthy behaviors. But it is difficult to meet with traditional methods since they are quite resource intensive. And then there's a great potential in mobile health or eHealth interventions that are delivered through mobile phones. They have also shown some promising results, and they also have proven to be cost effective. But something that we kind of discussed before submitting the application was that these unhealthy lifestyle behaviors tend to cluster. And addressing multiple behaviors may result in an increased confidence in the capacity of change and also enhance effectiveness. So that's one of our primary aim is then to kind of have a joint effort around the multiple behaviors. So that's one theme of our program. So the overall aim of the MoBILE research program is to design, evaluate, and then implement 7 state-of-the-art eHealth multiple lifestyle behavior interventions, which can be delivered by healthcare to support a healthier lifestyle in different populations across the lifespan. Of course, we have a lot of specific aims. I won't go through them all, but I highlighted in red some of the key words that we are looking into: user requirements. We are looking at effectiveness, then of course. We are looking also at who benefits from the different interventions, mediating effects, also if the effect differs by socioeconomic status and or migrant background. And another important theme is to tailor our interventions to socially disadvantaged groups. The implementation aspects, of course, and also to kind of build some capacity for the future in terms of the program to keep running after the 6-year period. And to make it more sustainable and also for knowledge dissemination, of course. This is a figure showing the 7 trials that we are doing within the program. So we cover different populations, and then we kind of design the interventions similarly to make sure that we can kind of gain a lot of knowledge from them. And so we cover pregnant women and children, so that's maternity care and child health care. We do studies in young adults, high school students and university students, and also then several more clinical populations from primary health care and also specialized clinical care. For instance, patients that are that has a surgery for their cancer to support their to support them in relation to that. We will also run a project in gestational diabetes as well. This is an outline of like a time plan. I won't go into the details, but you can kind of see that all projects are then following the same phases. So there are kind of 4 phases for each project that they follow. The first 2 phases are more the development of the intervention, while the third phase is the actual RCT, where we looked at effectiveness. And phase 4 is the implementation phase. A little bit about the status of what we have accomplished thus far. We are kind of 2 years within the program, and we are progressing well in accordance with the time plan. We have recruited 4 PhD students, and 2 of them are actually now doing their half-time in June. We have recruited 1 international postdoc. We have also identified and established collaborations for the projects more in the clinical care. We have started 3 RCTs that are now recruiting. We have published some study protocols and a few other articles kind of related to the project or the program as well. 1 with results and 3 more associated papers. We got some additional fundings from for some spin-off projects from the uni researchers that we're very happy about, of course. And we will also organize a PhD course in June 2021 then related to digital multiple lifestyle behaviors as well. And yeah, this is just the published protocols if you're interested. I will finish off my presentation because we actually don't have any results from the RCTs yet, which of course is a pity, but they will come soon. But to give you some examples of what we have done so far, I will show you a couple of screenshots from the interventions that we have developed. So this is from the child healthcare project. The project and also the app is called the Ministop 2.0 because it builds on a previous project. I mean, one major thing with this project is that we deliver this intervention in different languages, and so we have tailored it for different populations, which is very important today, so that we don't just build interventions that only the resourceful and people with high education can gain from. This slide illustrates that this app is available in English, Arabic in the middle, and also in Somali. That are the major languages speaking for this target group. This app is a support for parents having a 2-year-old, supporting healthy behaviors, diet, physical activity, and also prevention of obesity. And this RCT has started. We have recruited almost 350 children thus far, so it's going well out of 500. And something that we learned, so these are a couple of quotes from the qualitative work that we did in the beginning, is that one nurse said that it's important to use pictures. It should be as uncomplicated as possible. Not everyone reads well. So we took that into the intervention, and we provide audio files in Somali and Arabic to make the intervention more accessible. So that's we're very happy about that. Another thing that came out of these interviews is a parent said that a bit of encouragement on that it's temporary, that you shouldn't stress too much when things are not going the way you would like them to. And this illustrates that we got parents saying that we want very clear guidelines. We want how much vegetables should a 2-year-old eat? What is healthy for my kid? So some parents wanted very clear guidelines, but other parents, like this parent, more expressed a stress about having all this information. So that's something that we also built into the intervention, so that we are we try to balance that, clear guidelines and instructions, but also a very, parental support and understanding that it's a lot of information for them to handle at this stage, of course. So just to illustrate a little bit on what we can learn from the qualitative work and the development of the apps. This is another example from the Life for Youth, which is the project in high school students. This project is led by Ulrika Müssner. And from the high school students, we got quotes about, social support and peer support, that you behave unhealthy if your friends do, you behave healthy if your friends do. So I mean, that's not a surprise, but it's good to kind of really get it from the target group as well. They also expressed that there are a lot of influencers and other sources of role models. So that's something that came out of these interviews as well. And this was also kind of, we brought this into the intervention as well. And RCT is ongoing, and we are recruiting for the high school students. So a little bit about more, the social support, and also a little bit about the stress as well, and building on these things. So that's good. And finally, the project called Buddy in university students, led by Marcus Benson. And here's also a quote coming out from that study. The university students more raised questions actually to economy, aspects regarding their economy or their financial situation. Because of course, as a university students, you don't have a lot of money. So that will kind of lead you to unhealthy or healthy behaviors dependent. So that was an important factor. Not a surprise either, but still kind of good to really get it out from the interview so that we can really use it in the intervention. And that study is about to start. We're about to start recruitment for that study as well. So finally, some lessons that we kind of learned during this 2-year period thus far is that, as I've already kind of given you some examples of, different target groups have different requests. So that's very important to kind of bring into the intervention. So we are trying to do that. Something that we learned also is that bridge builders, that are kind of people working in primary healthcare, at least for child healthcare, Somali-speaking women, for instance, they have been an amazing and crucial resource when adapting the eHealth interventions for non-Swedish speaking families. They have been so helpful and so great, and really helped us a lot. And so, if you're going to do something similar, I would really recommend to bring these people on if possible, because that's great. We also had some challenging about the tailoring and translation, but it was more related to actually the translation, which I didn't expect, because I thought that the actual translation of the material was more like a service that you buy and pay for. But we had a lot of challenging on that part. We got back material that said that the families should eat more like trees instead of vegetables. So we in our mind, we had kind of pictures coming up with Somali families being out in the woods, looking for trees. So that's kind of, and so that was kind of not expected, but a real challenge. We solved it in the end, but we had to kind of really fight these companies to really to get a good translation, and we also had a lot of help from Somali speaking and Arabic speaking co-workers that we also brought on to make sure that we got good material. Something else that we are kind of thinking about is, primary healthcare and healthcare, they want eHealth tools, they need them, but to be able to give it to them, we need to be able to evaluate them in RCTs, and that's a tricky part, because that will mean work for them. They need to recruit participants, they need to be able to randomize and kind of do this project work around it, and that could be challenging. And we have experienced that as well within the child healthcare, that it's a lot of work for the staff. So that's something to kind of think about if we can do it in another way. And a positive point in the end is that you can actually recruit in child healthcare, although COVID-19. So we are very happy that we've been able to recruit 350 children during 2020, although COVID-19 was very present for us all. So we're very happy to the staff that they were able to help us in any way.
Thank you very much, Marie, for inviting us to this seminar. I really appreciate the initiative. And I must say, I'm really impressed over the research that you are doing. And I realize that we have many things in common, and that's promising. So my name is Inga Christensson Hallström, and I'm professor in pediatric nursing at Lund University. So the research that I'm going to present is the one eHealth as an aid for facilitating and supporting self-management in families with long-term childhood illness, the development, the evaluation, and the implementation in clinical practice. This very long title is shortened to eHealth. And as Marie said, this is also a research program funded by the Swedish Research Council for Health, Working Life and Welfare. It's a 3+3 year research program starting in 2018 with a total of about 28 million Swedish crowns. And this is actually continuing from another 6-year research grant that I received in 2013 called Lund University Child-Centered Care. So the research could continue for 12 years, and we are very happy about that, of course. Some of the projects included in eHealth is also part of another research program called iCope, which stands for Interregional Childhood Oncology Precision Medicine Exploration, funded by the European Union. And we do that together with the hospitals both in Lund and Malmö, and also in Copenhagen, and universities in Denmark. So for those of you who don't know me, I'm a pediatric nurse, and I am since 2002 the research group leader for a multi-scientific research group called Child and Family Health at the Faculty of Medicine at Lund University. And we have a long-lasting collaboration with a lot of other universities and healthcare organizations in many other countries. For example, Denmark, Iceland, the Netherlands, Ethiopia, Canada, and Australia, who is also, and they are also involved in this research about eHealth. This is one of the few pictures showing when we were able to meet in real life. And this is only a part of those participating in this research program. We are used to use Zoom even before the pandemic, because we have many other collaborators in many other different countries. In our research, we use the perspective of child and family-centered care, but we also use a framework for complex interventions, originally from the United Kingdom, and it's a model for developing and evaluating complex interventions from the Medical Research Council in the UK. And as you can see, it has 4 different phases: development, feasibility, and/or piloting, evaluation, and implementation. In our research, we also use participatory design, where we involve family members and healthcare professionals to develop the interventions that we are aiming to test and to, if proven sufficient, also implement. Sorry. I have for many years now, almost 25 years, been interested in what the needs of the families are when a child gets a long-term illness. So for many years, we have followed children where the child is diagnosed with a long-term illness. And this is just showing some of the doctoral theses that we have produced. And from the needs of the family, we have tried to develop and evaluate hospital-based home care for children with long-term illness, because children who are ill, they want to be at home as much as possible. But over the years, we have seen that children and at least the parents are very interested in getting a more support from eHealth in different ways, to be able to get the support that they need when they take care of an ill child at home. So this was the reason for eChild Health. So the overall aim of our research program is twofold: to stretch the borderline regarding the present knowledge of clinical and economic cost effectiveness of eHealth as an aid for facilitating and supporting self-management in families with long-term childhood illness, and also to develop a sustainable multidisciplinary research environment for advancing, evaluating, and implementing models of eHealth to promote self-management for children and their families. In our research program, we have 11 projects, and the first 5 of those, it's about an eHealth application to get a safe bridge between the hospital and the home for children after neonatal care, after surgery, for congenital malformations, for children with congenital heart disease, and also for children in pediatric oncology care. And this research is done both in Sweden and in Denmark. As I said before, we have a collaboration with in another project as well. There is also another project ongoing in Denmark, originally from Hillerød Hospital. It's a smartphone application for early prediction of cerebral palsy in young children by the use of general movement assessment. We have one research project in the south of Ethiopia, and that is about SMS reminders for improving adherence to antiretroviral therapy among adolescents living with HIV in Ethiopia, in a region called Arba Minch. And throughout all these clinical projects, we have 4 projects ongoing about the technical development, about health economy, about cultural perspectives, and also about implementation. So if we, I will focus on the clinical projects where we used in Sweden at the Children's Hospital in Lund and Malmö in my presentation. So what have we've been doing? Well, we have developed an eHealth application for Android-based computer tablet based on the parents' and professional needs. And this type of portable mobile device serves as a self-contained medium for delivering the eHealth solution. They are battery-powered and rechargeable and have a relatively big screen with touch controls. So you can say it's quite an ordinary iPad. And the tablets are equipped with SIM cards, providing a plan for data traffic to ensure uniform network access. So we are not putting the requirement on families to have home internet access. The tablets are locked down to a third party, so they are not able to use any other functions than the eHealth app for security reasons. For example, it's not possible to use any web browser or any games. The tablets are designed to be always on for interruption-free operation, and timely notification and communication. So the tablets are delivered to families in kits, included the tablet, a charger, general information about the research study, and instructions for use with contact information to the development team. So you can say that this overview, very simple overview, is shown in this overview. So the central concept is that the family is issued a tablet that they take home when they leave the hospital. It operates by communicating wirelessly with a remote centralized server where all patient data is stored securely. At the other end of the system at the hospital, nurses and physicians can monitor the patient in a web browser from their regular computer. And the difference between using Zoom and Skype and Teams and other parts is that this is the security. It's not possible to get into the data that the parents or the professionals are sending through the cloud. And in the parents and the professionals can communicate through chat, video, pictures, text messages during the time parents need support after their child's discharge from hospital. And parents can also use specific data for the child, like weight, feeding, vomiting, stooling, wound care, and so on, based on the specific needs in the different areas. And by the use of participatory design, we involve parents and healthcare professionals, so the specific needs in the different areas are developed and put in place in the application in the specific areas. This picture shows the progression for our clinical projects. As you can see, we have come to the evaluation. We have done the development and the feasibility studies and we are now in the evaluation phases in neonatal care and in pediatric surgery. In pediatric heart surgery, we have only started the development phase, and in pediatric oncology care in Lund, and also for the next one, intravenous infusion therapy in Denmark, we have come to the feasibility phases. So the parents are and the families are right now testing the application at home. In the cerebral palsy study in Denmark, we are right now to start the evaluation phase. And in the Ethiopian study, we have been forced to change the process according to the pandemic situation. We have, as I said, we are evaluating the phases and the progress in the different areas in different ways, with a lot of questionnaires for both professionals and the family, but we also interview them. And this is just a few quotes from the interviews we did during the developmental phase. And we have seen that parents and also professionals are very happy about the possibility of communicating with parents or with the hospital staff when their parents are at home and taking care of their child. Well, I will come to that a little bit later, but we have seen that there has been a lot of possibilities for us during the pandemic situation, but also, of course, some some hindering factors. So the lessons that we learned, as I said, the COVID pandemic situation has affected us all, of course. In those projects where we were already on our way and had developed and tested for feasibility and were able to start the evaluation phases, it was extremely useful and helpful, both for parents and staff. And it really made an impact on those families' lives. But if we hadn't come that far, it has been difficult for us to proceed during the pandemic, because we are not allowed to start any projects at the Children's Hospital, and the professionals in pediatric care, they are extremely burdened by taking care of patients, of course. We have also seen that the scars of technical staff have hindered an efficient development, because we haven't been able to recruit a PhD student in the technical area, where we had 2 that were supposed to start in our project, but they were offered much better solutions, or at least salaries, in the industry during the COVID situation. So this is a problem for us, and a challenge for us. So in the future, we are looking, as I said, during the different projects, both on cultural, health, economic, global, and implementation perspectives. And we also, of course, hope that the pandemic situation will ease, so that we can continue what we have planned. So thank you. Thank you for listening.
Thanks a lot for inviting me to these presentations. So I'll use the next 20 minutes to talk about our Forte program, STACI, which is based at Umeå University. My name is Navi. I'm professor of global health, currently at University of Gothenburg. But when I wrote this proposal together with the teams, I was at Umeå University working as a professor of epidemiology and global health. And since I moved half a year after we got this project, I have a guest professorship at Umeå University to continue leading this project from distance. So the project which I'm going to talk about is called STACI. We don't really like the long title, but we like the fact that we are funded. So we got this STACI as an acronym of a sustainable behavior change for health, supported by person-tailored, adaptive, risk-aware digital coaching in a social context. So there are quite a lot of things blended in this project. And I'm presenting this on behalf of my team member. Okay, let me take this one. So this is a multidisciplinary collaboration between 4 different faculties at Umeå University. We come from Faculty of Medicine, Faculty of Arts, Faculty of Social Sciences, and Faculty of Science and Technologies. So to me, I think this is a truly multidisciplinary collaborations, and we work quite closely with the region Västerbotten from the conception of this project. So that poses a bit of challenge also, because we come from different research culture, and we work closely with the implementers, which is the soul of this project. So when we designed this project, we thought that whatever we are going to do in this project should be useful beyond the lifetime of this project, and it should be useful for the region at large. And hence we have very close collaboration with the region from the time we wrote the proposal and from the ongoing works also. So we also got the money at the end of 2018. So formally we started in the beginning of 2019. So we are now in the 2nd years. Unfortunately, we had 1 year due caused by the COVID that we are a bit lagging behind in terms of what we can achieve. So, but let me tell about the background of this project. In the Västerbotten region, since 1990, the whole regions implement what they call as a Västerbotten intervention program. So it is an intervention program targeting to reduce chronic non-communicable diseases, especially chronic coronary heart diseases. Västerbotten, as one of the northern regions in Sweden, has had a very high mortality rate due to ischemic heart disease back in the 70s and 80s. And that prompted the politicians to launch this program in 1990. So in short, it is a multimodal interventions targeting a lot of pieces. But from the university, we are involved quite closely with the two yellow parts, which was the health survey among people who turn 30, 40, 50, and 60, and also the health counseling. So everyone who turn 40, 50, and 60 every year, they are invited to their closest primary healthcare center to fill in questionnaire as we see on the right-hand side, as well as being measured, blood pressure, blood sampling, and so on. So 2 weeks after the examinations, they come back to the primary healthcare center, where a nurse give them feedback about the results. And the results, since the conception of this project, has been presented in the shape of a star. So it combines information about their smoking behavior, lipid levels, alcohols, BMI, and so on. So for 25 years, the results have been presented on paper. And it shows, for example, to start with, people have the shape of the star, which looks like the yellow line, the red line, the one in the middle. So which means, for example, they smoke, they have very high lipid levels, and they probably have poor diet and so on. So this is one way of health communications to the patients in giving back the information from the survey. If they change their behavior, they might have a star which look like the outer line, the green star. So as we mentioned, so for 25 years, this star has always been on paper. And we thought that that was not a durable solution, it's not sustainable for long term. And now with technology development, we thought that it should be possible to develop a technology platform where we can show the star to the patients and try to tailor or personalize the coaching. Because we see on here, I mean, it was based on a one-to-one meeting with the nurse. It happened 2 weeks after the interventions. If a person come to the nurse or to the Västerbotten intervention program when that person turned 40 years old, that same person will not come to primary healthcare center for this program anymore until he or she turn 50 and 60, which means that in between these periods, we don't have any intervention for the persons. So the idea is to develop a technology platform which will allow us to be in contact more closely. When I say us, I mean the region of Västerbotten. So they could use these informations to tailor the digital coaching for promoting healthy behavior. So we also thought of that it's possible to explore adoption of this technology in different social contexts beyond the populations that we target or the region target in the healthcare setting. And the third focus of STARSI was to co-create knowledge and knowledge base and have a close collaboration between the researcher and the user, the professional in the primary healthcare setting. So unlike the other two projects, I mean, we work very, very, very closely with the regions, and that somehow posed challenge during the COVID situations, because for the whole last years, I think the healthcare has been overburdened with emergence of this COVID-19, and quite a lot of activities has been stopped, including the VIP in Västerbotten. So many healthcare centers, they have stopped the VIP recruitments during 2020. And that somehow leads us to change our designs, which I'm going to talk a bit in a while. So we have 7 objectives in a 6-year program. In the application, we promise to do the first 4 objectives in the first 3 years. So the first 3 years are very research intensive. So we try to model health behavior and see if health behavior change over time. Since we have access to this Västerbotten intervention program data for 25 years, we would be able to see if people came when they were 40, what would the risk behavior be when they were 50 and 60. So we use panel data to model risk behavior trajectories. And then we thought that it's important also to assess the social environment and social network for behavior change purpose. We heard from people who came to the VIP, they told us that they actually talked to their family member, they talked to their co-workers in the office. So we were unsure actually how far the outreach of VIP beyond the people who came to the healthcare center. So that's the aim of the second project. If it's possible to understand the network of people and how information spread beyond the initial target group of the VIP at the primary healthcare center. And we also propose to study the use of social media to spread health information. And using the results from these three findings, first three projects, we plan to create user-centered designs platform developments for digital coaching. So those are what we plan to do for the first 3 years. And the next phase, we thought that we will do randomized cluster randomized trial to evaluate the implementation of the coaching program, as well as to evaluate, at the same time, evaluate the cost effectiveness. And we have one work package on ethical issue, which actually run across all these work packages. Is it ethical to talk about my smoking behavior to my coworkers? Is it ethical to post my physical activity behavior on social media? So we thought that a lot of ethical issues surrounding the use of social media and spread of information through social network that would be very interesting to study. So as we see in this graph, I mean, the different projects have been designed consecutively. It means that they follow one after another. Unlike the other two projects that Maria and Inga presented, we designed the project a bit differently in UMIL. So quickly about the activities, those are the activities that we thought that we would like to do. A lot of qualitative interview, focus group discussion, especially in project 2 and project 3, talk with the family member, talk with the VIP participant, talk with the nurses, the implementers of the program. And those results will be used for iterative participatory user-centered designs to develop the digital coaching. So what I'm going to present next are a bit more detail on each of the projects, the research question and the achievement so far, while at the same time talking about the challenges as well as future work. So the first project focused on modeling behavior trajectory. So we have two questions: whether trajectory differs between different population groups, and what are the determinants of people changing their behavior trajectories, whether trajectory could predict NCD mortality and morbidity due to the rich data that we have on behavior changes. So we haven't managed to answer the second objective because we are still waiting data from social citizens, linkage of VIP data with mortality and morbidity data. So that will come hopefully spring this year. But regarding trajectory, but due to the developments, we thought that we should continue the research. So what we did, or what we experiment, was to do a Facebook survey. None of us in the team had any experience to do an online survey. So we thought that that could be a learning process for us also. So what we had planned to do in person in healthcare center, we transform it into a Facebook survey. We ran this survey starting in November and end in January. So we had data during 3 months. We asked quite a few of questions. Since we run into the COVID situation, so we have to adapt the instruments, and we have a special section on COVID pandemic and the consequences to people's health, and also how COVID have influenced their health behavior and their intentions to change their behavior. And we also include, because one of the project aimed to look at social network. So we ask question about if people meet in real life or on social media during this COVID pandemic. And that will allow us to have some study looking at the correlation between few of these variables that we study. So for project 2, we thought of looking into social network and social environments. Here are the few research questions that we plan to ask. The role of social network in influencing behavior, if individual manage to change their behavior as intended by looking at the trajectory, and if the effect of social network gendered. So we will do a focus group discussion, hopefully starting this spring. I mean, we have all the infrastructure in place. Because of the changes in the recruitment process, we have to submit 2 addendum to the ethical committee, and that's somehow track the process a bit. But now we have got an approval to use another way of recruitment of the patients, not through the primary healthcare center, but through other mechanism. So project 3 on social media will also kickstart this spring using a focus group discussion and interview. And these are example of questions that we want to answer in this project. How people perceive the role of social media for their own health promotion. If people share their practice, or if people being influenced by practice of others, and if people share their practice on the platform. And the last thing I'd like to show is the fourth project on designing the tools. So here are the few questions that we had in mind to be answered during this project. To capture whether people have different motives for behavior change and how to use digital technology to capture those motives. And there are a few questions more technical on automatizations, reasoning, and digital decision making. So this part of the projects are being handled by colleagues from Department of Computing Science. So within this project 4, we had a development workshop and we asked these few questions and we got some answers that I present in brackets. So for example, we asked what behavior do we think that the app should focus on and who should be the target groups. There were discussion about the different lifestyle behavior that the app should focus on and the different types of social network that one should target. So that is what we have done, workshops and a synthesis of the analysis in this project. And what will happen next during this spring is a continuous dialogues with the interviewee, as well as a focus group discussion. So our ambition by the end of the 3rd year, hopefully we'll have something on the right. The star which used to be on the paper, hopefully will be on the apps already. And that will allow user or the patients to report changing in their behavior. Because as I mentioned, when the VIP star is presented on a paper, it's impossible for them to interact with a paper. But now hopefully it's possible for them to report their behavior change. And our ambition is that apps will be connected to the region office, primary healthcare center. So it's possible to connect the nurses in the primary healthcare center who run the VIP with the patient. I think I'll stop there. We haven't gone into the 4th year, so I'm not going to report the RCT and the other 2 parts of the project. Thank you very much, Marie.